Hello there, and welcome to this video brought to you by Atoza. My name is Garth. In this video, I'm going to be discussing awareness under anesthesia. You may have already noticed that I've not used the official phrase for this phenomenon, which is actually accidental awareness under general anesthesia. Don't worry, I will use it soon. I've specifically used the more vague term of awareness under anesthesia for a good reason. A key part of the anesthetist's role is to try to reduce the psychological stress or trauma of the perioperative period. Obviously, some stress is unavoidable, but there is a lot we can do to assist our patients, including preoperatively. This would be medical counseling, assessing support structures for the post-operative recovery period at home, addressing specific fears and concerns that the patient might have, and possibly giving an anxiolytic pre-medication. Post-operatively, this would involve preventing or treating pain and nausea, which cause significant suffering, feedback on how the procedure went, and explaining the daily management plan and what to expect. And then, of course, intraoperatively, this is where we focus our attention on trying to prevent the psychological trauma from the surgery itself. In practice, there are many different conducts of anesthesia that can be utilized to suit individual patient requirements and surgical or procedural requirements. Each anesthetic technique has different risks of or different elements of awareness and/or the potential for psychological stress. Here are some of the examples of the different anesthetic techniques I may use. Firstly, neuraxial anesthesia without sedation. Lower limb orthopedic surgery is probably my most common example. If appropriate, I do offer these patients the option of light or moderate sedation, but often the patients will say that they're feeling relaxed and would rather not have the feeling of being sedated. During the case, I again offer sedation to the patients. These patients are going to see, hear, feel, and remember many aspects of the theater experience, such as the temperature, blood pressure, cuff, squeezing their arm repeatedly, noises such as drilling, hammering, suction, and the conversations of the staff in theater. The theater team needs to be conscious of this and adapt their behavior appropriately. They need to have ongoing communication and explanation to the patient of what is happening. There needs to be repeated assessment of how the patient is feeling and their comfort levels, and many more examples that I'm sure you can think of. The next anesthetic technique that I often use is again neuraxial anesthesia, but this time with sedation. There are many patients who on counseling would like the benefits of neuraxial anesthesia over general anesthesia, but don't want to be fully awake in theater. Sedation works very well in this situation. I do counsel the patients that they may remember parts of their time in theater, but that in general, they'll feel sleepy and relaxed, and I will be there with them to give them more medication if the experience is unpleasant. Some of the same principles from the first example will apply here, as well as our next discussion, which is on sedation. So now we move on to the third type of anesthetic that I frequently give, and that is sedation, with or without local anesthetic infiltration or a nerve block. There are many procedures, especially day case procedures, that can be done safely and efficiently and comfortably under sedation. Procedures that I commonly do in this category include vasectomies, excision of facial skin cancers with local flaps, prostate biopsies, GIT endoscopies. The early use of sedation in the procedure makes the local anesthetic injections more tolerable for some of these procedures, such as local anesthetic infiltration into the nose, which is extremely painful. And then it also keeps the patient sleepy and relaxed for the procedure. The benefits of sedation here are faster theater turnaround times, faster readiness to discharge, less post-operative nausea and vomiting, less chance of a sore throat, and lots of other benefits. I do counsel the patients that they may remember parts of their time in theater. I specifically tell them what some of the unpleasant sensations are that they might experience. For example, in vasectomies, the two unpleasant sensations are firstly the injection of local anesthetic, which burns for a couple of seconds initially, All local anesthetic injections burn initially. It's something that we need to tell our patients. And then the other unpleasant experience in this procedure is that one can experience an aching or pulling sensation radiating up to the kidney region. Patients then know what to expect and when to communicate their discomfort if they do have any. I do, though, reassure them that in general they will feel sleepy and relaxed, and I will be there with them to give them more medication if the experience is unpleasant. And lastly, now we move on to general anesthesia. The aim of general anesthesia is to prevent all recall of events following induction of anesthesia up until the patient wakes up from the anesthetic. For the purpose of this talk, there are 3 steps in this process. Firstly, induction of anesthesia, then maintenance of anesthesia, and then emergence from anesthesia. It makes sense that during the transition phases, there is a greater potential for awareness. So on induction of anesthesia, patients will often remember going off to sleep, such as what was said to them, any burning sensation in the drip from the induction drugs, the feeling of the face mask on their face, perhaps even the feeling of the application of cricoid pressure on their trachea if it's applied. And so with emergence from anesthesia, patients often remember parts of that too. They may remember hearing voices in the recovery room telling them to breathe deeply or to open their eyes and wake up. They may remember the sensation of the airway device in the back of their throat, which can be quite unpleasant. And they will possibly begin to experience some pain as they wake up. It's difficult to get pain management perfect while patients are asleep, and as they wake up from their anesthetic, they might complain of pain. So part of our counseling process before an anesthetic should be to inform patients that they may experience or remember these aspects of their anesthetic. The maintenance phase of anesthesia should and does have a low risk of awareness for the patient. It does still happen though, and it has an incidence of between 1 to 4 cases per 1,000 anesthetics. And this now brings us to the correct terminology, which is accidental awareness under general anesthesia. So what is this accidental awareness under general anesthesia? The simple explanation is it's the patient recalling parts of the theatre experience, but it isn't really that simple. Firstly, we have already gone through the various examples of how and when a patient may be expected to recall aspects of their theatre experience. While this is not intentional, it is also not accidental. So we could say that it is, to some extent, expected. Secondly, we have to address the concept of recall. How does recall manifest? When does recall manifest? There are 2 types of memory formed in our minds. Explicit memory, this is conscious memory, and the person is able to recall the event. The memory may need some prompting though, and the memory may only present itself sometime after the event. We all experience this type of memory in our normal lives. We recall some things at will, but some memories are triggered by a new event, and suddenly a distant memory from the past comes to the surface. The same applies to awareness under anesthesia. Then the second form of memory is implicit memory. Here the person has no recall of the event at all, but experiences psychological and behavioral effects, such as anxiety or nightmares or other features of post-traumatic stress disorder. Accidental awareness under general anesthesia has the potential to manifest as implicit awareness. I hope now you are starting to realize some of the complexity of assessing or detecting or managing accidental awareness under general anesthesia. Firstly, it may need prompting to detect. It may present only after some delay. And it may not be something the patient can recall, but rather be a psychological or behavioral change. It is important to not think of awareness as one big group too. Not all awareness is the same. There are degrees of expected trauma or stress from different types of awareness. For example, if you're having an anesthetic and you are aware of the surroundings, you're aware that you're in theatre, but you are comfortable and relaxed and you're not under any distress, that's not as bad as perhaps being under anesthetic and hearing voices, hearing the surgeons talk about the struggles they're having during the operation, or not being certain of what the next step is, or just hearing random people talk and not being able to respond. Worse than that still could be being under anesthetic and feel touch or movement, but not being able to react or respond to it. Even worse than that would be feeling pain or discomfort. That pain could be the pain from the surgical stimulus, it can be the pain from the breathing apparatus in the back of the pharynx, and even something as simple as secretions pooling in the back of the pharynx can cause a lot of discomfort. And then probably the worst type of awareness is when someone is aware of the fact that they have pain, that they are being operated on, but they are paralyzed. They know that they are paralyzed, they feel like they can't move, like they can't respond, they can't open their eyes, and they're trapped in that situation and they are having pain. So not all types of awareness are the same. Why does accidental awareness occur though? Well, there are numerous potential factors that lead to it, and I will go through some of the more common ones. Firstly, there are patient variabilities in anesthetic needs. Not every patient requires the same dose or the same type of anesthetic. This can be because of pharmacokinetic variability. This is how the drug levels change in the body. That's got to do with distribution in the body, metabolism by the liver or the kidneys, excretion by the liver of the kidneys. Different people have different pharmacokinetic processing of the drugs they receive. Then there's also pharmacodynamic variability. This is how the drug affects the body. Examples here of the variability are pregnancy, where we know certain drugs are required in higher dose. Younger age also often require higher doses. Patients that are using recreational drugs or who are addicted to opioids, these patients are tolerant or dependent or used to these drugs, and so they require much higher doses of anesthetic drugs. Hypermetabolic states can also affect this, such as hyperthyroidism. These patients may require higher doses of anesthetic drugs. Obesity. Drug dosing in obesity is extremely difficult to know when to use the total body weight, when to use a body weight that's just based on muscle with no fat, when to use sort of a body weight in between those two. Smoking. Smoking is known to increase the requirements under anesthetic, as well as heavy alcohol use. So those are some of the pharmacodynamic differences in how patients respond to drugs. Thirdly, there can be drug tolerability issues. And the most common we see in theatre is the cardiovascular instability that results from anesthetic drugs. And in certain patients, this can lead to underdosing of anesthetic drugs as we try to walk a fine line between the negative effects of the anesthetic drugs on the cardiovascular system, that is hypotension, bradycardia, arrhythmias, and hypoperfusion of the tissues, and we have to balance that against the hypnotic benefit of those drugs. And the classic examples here are trauma surgery, patients that are rushed to theatre in a critically unstable condition, and then also cardiac surgery. Patients have major cardiovascular abnormalities, they might be in heart failure, and they cannot tolerate normal doses of anesthetic agents. Fourthly, there can be drug and equipment issues. These include drug errors, where you think you've administered the correct dose or the correct drug, and you have actually underdosed. It can be equipment failure, such as vaporizer malfunction, intravenous line disconnections, your intravenous line tissuing, those types of things. And lastly, accidental awareness occurs because of the difficulty in detecting awareness under anesthesia. And there's lots of reasons for this. For example, muscle paralysis is known to increase your risk of awareness by 50%. That's because patients that are paralyzed can't twitch or move or have facial grimacing. They can't give you those signs that they are actually experiencing awareness. There are other drugs that can also mask awareness, such as beta blockers, that will mask hypertension and tachycardia. So, prevention of awareness is the obvious goal of general anesthesia, and we will highlight it at numerous points during this video series. We will also discuss it later on in this video. For now, let's look at what to do if accidental awareness has occurred. So firstly, what to do if you suspect intraoperative awareness? Well, the first step is obviously to deepen the anesthetic. And the fastest way to do this is to give extra intravenous induction agent. So if you have some propofol left in your syringe from the induction, you can give an extra dose of that, or you can draw up a new amp of propofol and you can give an extra dose of propofol. You can also use a benzodiazepine in this situation. So an example would be giving 1 to 2 milligrams of midazolam intravenously. Midazolam has the benefit that it may also cause retrograde amnesia. So it deepens the anesthetic going forward, but it may also cover some amnesia for the few minutes before you give it. We want to ensure that there's adequate analgesia. So depth of anesthesia, movement, surgical stimulus, there's a balance between all of those factors while you're giving an anesthetic. And if someone has moved in response to a surgical stimulus, it can be because they are aware. It can be because they're aware and they have pain, or it can be that they have pain and it's a reflex spinal arc causing the movement. And so we want to make sure that they are adequately analgesed. And if possible, we want to avoid further doses of muscle relaxants, possibly even reverse the muscle relaxation that might still be present if it's no longer needed. What this means is that because we've had a suspected episode of awareness, this patient now might be at risk of further episodes of accidental awareness during this anesthetic. And so reversing the muscle relaxation improves our ability to detect further awareness. We want to make sure that we follow up this patient closely post-operatively and assess for accidental awareness too. So, what to do now post-operatively if the patient reports accidental awareness? Firstly, this is something that you have to be prepared for. The incidence of accidental awareness is common enough that it's likely to occur within your career as an anesthetist. This is especially true if there is a particular case where during the anesthetic you suspected accidental awareness. Communication with the patient is vital. We need to validate their concerns and offer our sympathy. We need to explain how awareness may occur despite our best efforts to prevent it. Awareness doesn't mean that you've necessarily done something wrong. You could have given the perfect anesthetic, but awareness could have still occurred due to factors that are beyond your control. You need to document all conversations with clear details of the timing and type of event. You need to contact your medical insurer and all the seniors in your department for their advice and assistance. And you need to follow up with the patient at regular intervals. You can also offer them referral to a psychologist if it's required. In terms of assessing clinically for accidental awareness, the Bryce questionnaire is the recommended tool to use, and this is because it's a series of questions that are asked in a non-leading way while still trying to prompt any explicit memory. The questions are as follows. What is the last thing you remember before your anesthetic? What is the first thing you remember on waking up from your anesthetic? Did you have any dreams during your anesthetic? Remember that dreams may occur in up to 1 in 20 normal anesthetics. What was the worst thing about your anesthetic? And what was the next worst thing about your anesthetic? Assessing for implicit awareness is much more difficult, as the patient will have no recall on the Bryce questionnaire. To do this, we have to inquire about symptoms, such as nightmares, sleep disturbance, anxiety. Right, so now we get to the topic of how to prevent or limit the chances of accidental awareness under general anesthesia. This is a huge topic. It includes everything, from inserting a good intravenous line that doesn't tissue during your anesthetic, to high-tech monitoring to try to detect awareness. We can't cover all of this information in one talk, but we hope that this video series will help you conduct your anesthetics in a way that reduces your chance of accidental awareness and improves your safety across multiple aspects of anesthesia. I do want to cover or draw your attention to, firstly, clinical indicators of awareness, then volatile anesthesia versus total intravenous anesthesia, how to deal with high-risk periods during the anesthetic, how to deal with high-risk patients for awareness, and then lastly, depth of anesthesia monitors. So let's get into that. Let's start by looking at clinical indicators of potential awareness and discuss some of the issues around their use. Firstly, movement. We know that spontaneous movement by the patient is a potential sign of accidental awareness under anesthesia. There are some problems with this though. Obviously, patients that have been paralyzed with a muscle relaxing drug are not able to move, and that's why the use of muscle relaxant agents increases the risk of awareness by about 50%. There are other causes for movement too. By definition, the MAC for volatile anesthesia is a level at which 50% of patients move in response to a stimulus. So we know that even at a level of 1 MAC, or at the target MAC, patients might still move. There are also spinal reflexes that might cause movement. So not all movement is awareness, but movement is definitely a potential sign for awareness. And movement is generally not appreciated by the surgeon while they're trying to operate. The next one is spontaneous ventilation. Spontaneous ventilation is like a form of movement. When the patient experiences an unpleasant sensation or pain, they often start triggering or fighting the ventilator, and it can be a sign of accidental awareness. Next, we look at tachycardia. There are numerous causes of tachycardia, from fever, metabolic causes, endocrine causes, pain. So there are lots of causes of tachycardia, but tachycardia is one of the early warning signs for accidental awareness. There are numerous drugs that can mask tachycardia as well. If we look at drugs such as beta blockers, they reduce the chances of tachycardia, and there's drugs that themselves cause tachycardia, such as some of the anticholinergic drugs. Hypertension is another potential sign of awareness under anesthesia. Again, hypertension may be masked by antihypertensive drugs, by opioid drugs, by volume depletion, bleeding. Those patients are unlikely to become hypertensive. Sweating is another example. Pupillary dilatation. To be honest, I must admit that I've never taken the eye patches off a patient under anesthesia to look at whether their pupils are dilated, but during that stress response of awareness under anesthesia, there will be a sympathetic release and the pupils would dilate. Tearing is definitely a sign of awareness under anesthesia, and that is something that I do look for. Facial grimacing is another sign, and where possible, when I'm giving an anesthetic, it's not always possible, I do try to have the patient's airway and head and face exposed from under the drape so that I can see if there is movement or grimacing or biting on the endotracheal tube or tearing or any of those features. But often the surgery actually requires that the patient's head is also covered. So in summary, we definitely want to be paying attention to these clinical signs during our anesthetics, and we definitely want to have a low index of suspicion for awareness, but they are not always easy to interpret. Now let's look at the difference between volatile anesthesia and total intravenous anesthesia. In this video series, we haven't actually included a lecture on total intravenous anesthesia, but we hope to do so in the future. Volatile anesthesia allows for direct measurement of volatile level by sampling the gases at the Y connector. This has a large theoretical advantage over TIVA. The volatile monitoring, though, is not perfect.
This is for a few reasons. Firstly, we still aren't measuring volatile level in the brain. We are measuring end-tidal volatile level in the lung. Secondly, end-tidal volatile levels are only meaningful at steady-state situations. This is discussed in detail in the video on volatile anesthesia. Thirdly, there are still significant patient variabilities in the response to volatile anesthetic dose.
TIVA, on the other hand, carries extra risks of infusion disconnections, tissued lines, drug errors, and lots of others. And it's a model technique with no actual monitoring of a drug level. Next, I want to highlight some of the dangerous periods for awareness under anesthesia. Earlier in this talk, I spoke about the transition periods of induction and emergence. The other transition period is at the onset of surgical stimulus. We will talk about this in detail in other videos, such as the video on general anesthesia for cesarean section, where we look at the concept of mind the gap. But briefly, for this video, what we're talking about for mind the gap or awareness at the onset of surgical stimulus is the phenomenon where we've given an intravenous induction agent and the patient has gone off to sleep. That induction agent is immediately starting to decrease in level within the brain. And so we've turned on our volatile anesthetic, but that level is still rising. We're potentially not yet at steady state. In addition to this, we often face hypotension during this period because we now have the balance of some induction agent, some volatile anesthetic, and no surgical stimulus yet. So hypotension is quite common immediately after induction. And then the surgical stimulus starts. And we aren't actually sometimes certain of whether the patient is deep enough at that point. And that represents a high risk point for awareness under anesthesia. And the term is to mind the gap, to be aware of this potential and to deepen the anesthetic just prior to surgical incision, either by increasing the volatile concentration or by giving a repeat dose of your induction agent, obviously at a lower dose. Next, I want to highlight some of the high-risk patient groups. Earlier in this talk, we looked at factors that contribute to accidental awareness under general anesthesia. There were a number of patient factors listed in that section. When anesthetizing patients who are at higher risk of awareness, I do change my conduct of anesthesia. I am more likely to give a benzodiazepine pre-med to these patients. I am more likely to incorporate a benzodiazepine into my anesthetic, even if they've had a benzodiazepine pre-med. I will certainly include regular ketamine doses in the anesthetic too, probably at around 0.25 milligrams per kilogram every hour. I will target a higher end-tidal volatile level with a MAC multiple of around 1 to 1.2 if the hemodynamics permit. I will try to avoid muscle relaxation if possible, and I may consider using a depth of anesthesia monitor. We don't cover cardiac patients in this series as it's beyond the scope of the trainee anesthetist, but we will cover pregnant patients in detail in later talks, and we do also cover anesthesia for the unstable patient, which really our focus is on recommending that you do a ketamine-based anesthetic for its specific cardiovascular stability and the fact that it can aid you in preventing awareness. And so lastly, we come to the very interesting and controversial topic of depth of anesthesia monitors. There are various monitors available on the market. All of them are a form of processed EEG monitoring. They're processed because they don't display the actual EEG from the brain, which is very complex to read and to interpret, but they rather convert the EEG information via algorithms into a number range. How they work is you place electrodes over the patient's forehead, cables connect these electrodes to the monitoring device, and mathematically the device attempts to separate electrical input from millions of nerves and from muscle fibers to identify the underlying brain wave pattern. We know that the brain wave pattern changes during the various stages of sleep and anesthesia. So this data that is recorded by the device is converted into a score, which is then used to assess the depth of hypnosis and the likelihood of awareness. As said, these monitors are an area of ongoing research and debate as to whether they actually work and are of any benefit at all. I'm certainly not an expert on the topic, and if you're interested, I recommend reading this article that I found online. To summarize, here is my understanding of the key topics of debate. Firstly, the value on the monitor indicates the current balance between anesthesia and stimulus. It doesn't predict what's going to happen at the next step. It can't tell you if when the orthopedic surgeon drills into the bone, the patient is going to have awareness at that point. Compared to volatile anesthetic agent monitoring, there isn't any evidence of reduced awareness. So monitoring your end-tidal volatile concentration is equivalent to using a depth of anesthesia monitor in terms of preventing awareness. Compared to surrogate clinical markers of awareness, there is evidence that depth of anesthesia monitors reduce the incidence of awareness. So what these 2 points basically mean is if you're using volatile anesthetic and you have end-tidal volatile monitoring, there's probably no need for a depth of anesthesia monitor. But if you are using TIVA, where there is no end-tidal or concentration monitoring, then perhaps using a depth of anesthesia monitor there would be of benefit. However, I'm not personally aware of any evidence to show that these monitors reduce the chance of awareness during TIVA. There is evidence that these monitors can reduce anesthetic agent use, reduce emergence times, and so the thinking is that they are actually reducing anesthetic overdose. So they are preventing us from giving higher doses of anesthetic drugs to prevent awareness because they show that the patient is actually adequately anesthetized. Following on from this point, there is genuine concern about the short term, so within 7 days, and the longer term effects of anesthetic overdose. And so these monitors could play a big role in improving this situation. Regarding the monitors again, there is significant concern of the monitor's ability to separate out the electrical activity from the frontalis muscle, so the muscles on your forehead that enable you to frown and lift your eyebrows. So to separate out the electrical activity from those muscles from the electrical activity of the brain. Also, some commonly used drugs have unexpected effects on the value displayed on the monitor. A good example of this is ketamine. Other examples are etomidate and ephedrine. They might make the number that you're seeing unreliable. The next point is that the EEG response to anesthetic agents is not the same across all age groups. Different ages respond in different manners. So those are just some of the controversies and some of the points that people are debating when looking at these monitors. I do use depth of anesthesia monitors from time to time, but I think the take-home message is just that this isn't a fail-safe mode of monitoring. It's not the silver bullet. It's perhaps another monitor that you can use and that you need to interpret and think about and not just rely on blindly.
Before ending this talk, I want to bring up an absolutely fascinating, brilliant, and courageous study that was done by a group of anaesthetists in Australia. So the study is called The Response of the Bispectral Index to Neuromuscular Blockade in Awake Volunteers. It was conducted in Australia by Skiller, Newell, Strickland, and Barry. In this study, 11 volunteers were administered muscle paralysis with suxamethonium while being fully awake and having their BIS level monitored. And then a few weeks later, the experiment was repeated with rocuronium. So let's look how the study was performed. An isolated forearm technique was used to prevent paralysis in one arm of the subjects to allow communication with the subject while they were paralyzed. So they put a tourniquet on the subject's arm so that the muscle relaxant wouldn't reach the muscles in that arm and it would still be fully functional. Standard anesthetic monitors were placed and a BIS monitor was used on each patient. The subjects were then given the succinylthonium, or later the rocuronium, and then bag mask ventilated. They were given no sedation during the experiment. They were fully awake. Consciousness was assessed in two ways. Firstly, the subjects were asked a number of mathematical questions, and they had to answer the questions using the digits on their unparalyzed hand. And they did so with a 96% accuracy. Then the subjects were also told a story during the experiment and asked to repeat details of the story later, and they did so with a 94% accuracy. So the subjects were definitely awake and conscious and paralyzed. However, the BIS readings for the subjects dropped after administration of the paralyzing agents, even in the absence of any sedation, and they dropped to levels as low as 44 and 47, which are the proposed safe levels of adequate hypnosis in general anesthesia. The BIS levels didn't return to normal until the paralysis was reversed. And so the authors of this study concluded that BIS might be an unreliable indicator of awareness in patients who have received neuromuscular blocking drugs. And the suggested reason for this is a problem in the algorithm of the device, that it is actually detecting a loss of electrical activity in the frontalis muscle, as well as electrical activity from the brain. So for me, this study creates a big problem in the use of depth of anesthesia monitors, that when we most need to use them, that is in the paralyzed patient, the data they generate is not reliable. It doesn't prevent me from using these monitors altogether, as I think there are other instances where they may be useful, for example, in total intravenous anesthesia, in high-risk patients, especially if the patients aren't paralyzed, and in cases where one wants to reduce anesthetic dosing to prevent anesthetic overdose. And these would be in patients at high risk of cognitive decline following anesthesia, and that generally includes the elderly patients or patients that have some form of dementia or cognitive decline already. So I think this is an absolutely fascinating study. So that brings us to the end of this video on accidental awareness under general anesthesia. I hope that you've enjoyed it and that you've found it valuable. As always, please do send any questions or comments to us via email. We would really appreciate your feedback. And just a final explanation of the opening slide, which I've included here again at the end. This is the poster for the film Awake, which was released in 2007. And it's about a patient that had awareness under anesthesia. And a lot of articles reference this movie as a movie that increased public perception and interest in this topic.